Assalamu alaikum and good afternoon from Pakistan. Assalamu alaikum and good afternoon from Pakistan. It's early morning in Europe and quite late in US. Today we have a webinar on the subject of nuclear medicine in the time of COVID-19. We have distinguished panel speakers with us today. First, we have Dr. Liberto, who will be speaking from Vienna, from the IAEA headquarters. Then we have got with us Professor Stefano Fanti. He's based in Bologna, northern Italy, the place which has played a very important role how things have developed in this pandemic. And thirdly, we've got Professor Robert Wagner from Illinois, USA. He is with the Loyola University Health System. Along with these three international speakers, there are three faculty members from Shaukat Khanum Hospital, me, myself, Humayun Bashir. I'm head of nuclear medicine. Along with me is my colleague, Dr. Amna Hassan. She is a consultant nuclear physician based at SKM Lahore, and Dr. Saima Riaz, who is a consultant nuclear physician based in Shaukat Khanum Hospital, Peshawar. Now, down here. The slide is not moving. There's some problem with the slide. No, this one. Computer is just thinking this will sort out. Say it's not responding. Okay, while my colleague is working on the system, we can basically see that when this whole COVID thing started, the first thing that came to my mind was a very important short story, a science fiction short story published in 1909 by Ian Foster with the title of The Machine Stops. I read it way back in my O-levels. And that story was a story about a world where most of the humanity lives under the surface and all its needs are met by an omnipotent global machine. In that pretty high-tech system, the machine actually stopped and the entire structure of life started to unwind. This was what came to my mind as we're looking at the lockdowns. As I was wondering about this machine stop thing, I came across this article by Will Gobbett in BBC. He's the arts editor, and he mentioned, which is displayed over here, the machine stops is not simply prescient. It's a jaw-droppingly, gobsmackingly, breathtakingly accurate literary description of the lockdown life in 2020. If it had been written today, it would be excellent. That what was written over a century ago is astonishing. So this is the COVID world that we actually suddenly realized that we were into. It will be good, interesting if everybody can actually get a hold of this book and read it. Now, when the pandemic started, one of the initial response for any service like ours as well, and many across our country, was that nuclear medicine was standing with the institutions they were standing with the healthcare system, and they were standing with the society as the response was being managed and executed. Our physicians, primarily our trainees and nurses, they were in the front line of triage services for our institutions and our information from other places as well. So apart from doing nuclear medicine work, there was suddenly a call that we had to be part of a much larger clinical system, and we actually responded to it. Our scientists, technical, and the administrative team had to be reduced in compliance with the lockdown and other social distancing measures which were put in place by the institutions, by the government and the systems. Now, the immediate challenge for nuclear medicine was that the technician generators, what we had in our hand was it. The supplies, basically, because primarily in our part of the world, they come from international routes, international flights, they were stopped. Local resources were stopped because people actually working on the cyclotrons were actually, they had to be part of the lockdown. The consumables in our hands were suddenly we had to go back and count them because, to see how much we have, because there was definite uncertainty about further supplies and how it would come along. Gallium generators, the places which had a gallium generator, now they had a generator which was decaying. Patients reduced, generator decaying, not much to do. In addition to these consumables, the engineering bit was also put up to face the challenge. The corrective and preventive maintenance had to be adjusted, and there was a fear that if any part goes down, it won't be easy to replace that bit. So in this situation, the few centers, there are very few, like 6 or 7 in Pakistan functioning at the moment, PET suddenly became a very important thing because all the centers, they have on-site cyclotrons on the closed facility in that city. FDG could be produced. So we always have thought about that PET can be the one-stop shop which can do anything, because of specificity and utility of FDG traceability have many applications. So suddenly what we wanted to be a one-stop shop turned out to be the only shop open. So while technetium generator depletion reduced the clinical services NM almost to zero, the FDG PET scans could be done. So we carried on with that in our system, and similarly other centers carried on. Of course, there was an impact because of the lockdown. Not many people could actually move around to come and get their scans done. And of course, the clinical utility of the test was also under question. Generally, the surgical procedures have been completely halted, while chemotherapy and radiation procedures, when people were in the middle of these, they were actually continuing. So some flow of patients was still available for the PET services. And then within this, we have a sort of triage when to do an FDG PET scan or when not to do, because there are evidence-based tests. Suddenly, because the bone scans and other stuff was not available, the idea of looking into uncommon indications like doing a staging scan for a breast cancer patient in the colon or renal system, and again, because technetium maybe is not available, looking into cardiac viability. So FDG was not just the only shop open; it could offer a little more than what it used to do in the routine. And outside the imaging room, outside the in the clinical areas, or in the social media world, the clinicians, nuclear medicine physicians, scientists started talking about novel things. Once we have hit this point, the technetium can be disrupted. They started going back to new things which have been talked about in the past. That how can we make more use of cyclotrons wherever they are available? This we'll actually talk further with our representative from the NIA. Now, carrying on further. Now, when it came to resumption of services, the first demand to nuclear medicine service came from the breast surgeons. Actually, the institution worked out that breast surgery, day cases where with breast preservation and sentinel lymph node biopsy is required, they can be started given, because the patients were actually on the waiting list. So the first demand came from the breast surgeons. And we actually, once we got our first generator, we started doing those. The technetium generator supply started after a gap of say 2 weeks, coming via the cargo flights, and of course it was taking longer. They were arriving on site a little late with some decay, but they actually started on. And once it was in the hand, we of course, as mentioned earlier, we started with central lymph node, venogram, and bone scans as we were getting patients. As I said, to make hay while the sun shines, as long as we had a generator in our hand, we were running, here and there and finding anybody needing for scan inside the hospital and who can be safely done, taking all the measures of time distance shielding, ALARA, which of course now has a completely new meaning, because now we use time distance shielding and ALARA not just for radiation but also for infection purposes. All steps, similar steps. This is a chart just to display the blue lines of the technetium. So you can see that early on in the first part, the technetium we had in our hand, we could just do a few scans. The red line is actually the PET service which was running. This is still quite low as compared to service. We can do like 10 scans a day, and this is a report of the entire week. So we were doing a few PET scans, and then around the 3rd week of April, we got a generator through the cargo system. We had a peak. Then again, the PET continued, but we started having slight variation in that because of the lockdown, people could not move in. And we also became cautious of the consumables, how we'd be looking at. These spikes, the blue spikes are when we got the traces and the patient as well. This week here in 3rd week, 4th week of May was more of a holiday because of Eid holidays in our part of the world, so the numbers went down. But you can see the blue is on the rise. We are getting weekly generators, so that's back in. FDG, now here you see that, while the FDG was running all along, we can actually see a dip around 2nd week of that. Now, this is what I mentioned earlier on, the corrective preventive method. Now, there are technical problems with the scanners for which parts are required. Now, while we have got technetium, we can produce FDG. We have technical problem with the scanners for which the parts have to be flied in or brought in from abroad. So again, that is another factor which actually not just we anticipated, which will actually come to test as well. These small graphs here usually iodine inpatient because our floor was taken and made part of the COVID ward. The dedicated rooms had to be sort of locked off. We couldn't use it. Then from the older system of the building, we had one room available. So from this purple chart, we again started while we could admit 2 patients at a time. With one room, we could admit 1 patient, so we started that service. And while the inpatient was on, this orange line shows that we actually started treating a few patients as an outpatient service who could actually come down. These mountain sort of chart is a depiction of the previously shown bar chart. And the reason I like this, that my colleague made is nice. You can see these brown mountains are the FTG. It continued, sort of never stopped. We did have days when we didn't do it, but we thought we were there. The peaks, good week, the troughs, bad weeks, the tapering towards the end, we require a spare part which has to be flown in. The blue mountains at the back, you can see a small peak in the earlier, when we got the first generator, then peaks gradually as we are getting regular supplies. Small hills at the bottom, the green hills, they are the few DEXA lucky patient who actually walked into the hospital was not COVID positive and saved his one trip to the hospital. Otherwise, DEXA is not an urgent scan to be being done in a COVID situation. This one orange peak is the outpatients, iodine therapies. And then before we actually got the room, one room where we can give iodine therapy, you can see this purple lake developing. It's more consistent. We have one room where we are getting admissions, making admissions every day. So this is essentially about it from my side as an introduction. It's a reflection of our center, and that's a reflection of generally the centers which were able to, which have PET across Pakistan were functioning, and bigger centers which have technetium available to work on. After this, I would like to invite Dr. Lobato. He's a physician and technical lead at the Nuclear Medicine and Diagnostic Imaging Section, Division of Health Sciences at the IAEA headquarters in Vienna. As we all know, IAEA is the largest umbrella under which all nuclear medicine work goes on. Basically, the national societies and national systems as well as professional societies, they all take guidance from IAEA. So I would request Dr. Lobato to actually share his views on the situation and the contribution coming from IAEA and guidance for the nuclear medicine across the globe. Thank you very much, Dr. Lobato.
Thank you very much for the kind invitation. On behalf of Dr. Diana Paez and the whole team, the Nuclear Medicine and Diagnostic Imaging Section of the International Atomic Energy Agency, I'm really glad to participate in this webinar. And I'm going to tell you about the support that we have provided to member states during this pandemic. First of all, the IAEA is an independent intergovernmental science and technology-based organization within the United Nations family, and it serves as a global focal point for nuclear cooperation worldwide. And the mission of the IAEA is to accelerate and enlarge the contribution of atomic energy to peace, health, and prosperity throughout the world. Of course, always guided by the interest and needs of member states. And within the IAEA, the Nuclear Medicine and Diagnostic Imaging Section, or NMDI, the focus is on supporting member states to improve their capabilities in these medical fields through enhancing safety and quality of practice. And of course, during this pandemic, we had to switch a little bit some of our activities in order to respond to these needs of member states. First of all, we started organizing the first webinar entitled Challenges for the Nuclear Medicine Department on the 25th of March with 11 speakers and professional organizations from around the world. The second webinar was on April 16, and the title was COVID-19 Pandemic Guidance for Nuclear Medicine Department. The third webinar was Transitioning to a New Normal, When and How. Of course, these webinars also provided enough information to be able to publish editorials in the main peer review journals like this one, Guidance for Nuclear Medicine Department, published in the European Journal of Nuclear Medicine and Molecular Imaging, or Getting Back to Normality, the Nuclear Medicine Department after COVID-19, also published as an editorial in the European Journal of Nuclear Medicine. We have also collaborated with different scientific societies like ASNEC or SNMMI to develop guidance like this one, guidance and best practices for reestablishing of non-emergent care in nuclear cardiology laboratories during the coronavirus disease, an information statement from ASNEC, IAEA, and SNMMI. We also conducted several international surveys. This is the result of a survey in how COVID-19 affected the practice of nuclear medicine. We had 434 respondents from 73 different countries, and you can see here the results on the decrease of nuclear medicine diagnostic studies. Mainly, you see in green thyroid scintigraphy, lung scintigraphy, myocardial perfusion imaging, bone scintigraphy, sentinel lymph node. Of course, all of them were affected in different percentages in different regions around the world, but the practice, the general practice of nuclear medicine was affected for different reasons. First of all, the fear of patients to go to hospitals and get infected, or also the shortage of the provision of technicians and other isotopes and radiopharmaceuticals. The IAEA support to member states during this pandemic was in different ways. The Division of Human Health, also called NAHU, held 11 webinars, 3 of them organized by the Nuclear Medicine and Diagnostic Imaging section, with more than 6,000 attendees, and views of recorded session more than 13,000 from 144 countries. The first webinar was broadcasted only 9 days after the Vienna International Center, or the IAEA headquarters, went to lockdown. 3 papers have been published by the NMDI section in high-impact peer-reviewed journals: the Guidance for Nuclear Medicine Department, the Gearing Up Back to Normal, and the Guidance for Best Practices for Establishment of Non-Emergent Care in Nuclear Cardiology Laboratories during the coronavirus disease. We have also the first tech doc focused on COVID, that is IAEA COVID-19 Technical Guidance for Nuclear Medicine Departments. We have developed 20 videos on the use of RT-PCR in serology for diagnostic of COVID, developed and made available in English, French, and Spanish. So far, you can find only the first 10 in English in the Human Health Campus. I'm going to show you the link. And in cooperation with WHO, we have been working to develop technical specifications for X-ray, computed tomography, and ultrasound to handle COVID pandemic. The NMDI has provided technical support for the procurement of COVID-19 related RT-PCR items under the Technical Cooperation Project INT 0098 and other projects including more than 120 member states and more than 250 laboratories. Hundreds of requisitions were issued with complex proposals evaluated and clarifications and technical support provided to member states on ad hoc basis. We have also provided technical support for the procurement of portable X-rays for COVID-19. The requisitions have been issued, complex proposals evaluated, and clarifications and technical support provided to member states. And 3 international surveys have been conducted and the respective results submitted for publication. The impact of COVID-19 in nuclear medicine practices, the impact of COVID-19 in cardiac imaging, and the incidental COVID-19 findings in chest CT scan for patients undergoing PET-CT. And of course, we have provided technical feedback to the Office of Public Information and Communications of the IAEA for all COVID-related web articles, press releases, and bulletins. The support to member states has been provided to 120 countries with more than 250 laboratories. And the kit that we are providing to member states consists on RT-PCR detection equipment, plus other laboratory equipment like centrifuges, vortexes, consumables, primers, probes, and positive controls for the correct diagnosis and quality control of the equipment, biosafety cabinets, personal protective equipment or PPE. Many laboratories have received the diagnostic kits. You can see here some pictures of some of the counterparts around the world. So far, more than 150 laboratories have received the diagnostic kits. More are on its way, but we have a lot of challenges to face because of the limitation of equipment and materials in the market due to the high demand and the reduction of activities, the transport restrictions due to the travel bans. We have to identify potential channels for receiving donations and also identification of transport routes, and also export permit management times, requirements and management times for additional imports, sometimes difficult to meet in some countries due to local regulations. And of course, one big challenge is to provide training to member states. We are providing the equipment. We normally also provide the training for such equipment, but due to the travel restrictions, it has been really difficult. That's why we develop educational videos for the use of RT-PCR. These educational videos, you can find them in the Human Health Campus. You go, this is the front page of the Human Health Campus, then you look for the COVID-19 related information. Inside that, you're going to find 5 different links: the webinars, resources, other links, daily updated visuals, and the COVID-19 educational videos. If you go here, you're going to find the first videos developed in English on the use of PPE when receiving patients, receiving the patient at service center, collecting clinical samples from individuals, the proper sample storage and transportation, sample reception and processing, viral RNA extraction, polymerase chain reaction, and PCR results interpretation, as well as quality control. These are not meant to replace a face-to-face training course, but nowadays we cannot organize a face-to-face training course. So that's why we developed these educational materials as a support for the laboratories. We are providing this support to national reference laboratories, which means that they are already using RT-PCR for other purposes, other diseases, and now we are implementing the techniques based on the University of Berlin protocol and also using the University of Hong Kong resources like the positive controls developed in that university for the correct diagnosis of COVID-19. Of course, you have to know how to protect yourself and others according to the guidelines of the WHO. Keep distance, wash hands thoroughly, avoid shake hands and contact, sneeze into the crook of your arm or into a tissue, and stay at home when you have fever or cough. Recognize the signs of disease. You know this very well. I don't have to repeat it, but you have to be aware that COVID-19 is not only a respiratory disease. It could develop other symptoms. It could be gastrointestinal symptoms, neurological or cardiac symptoms. So you have to be aware of that. The disease symptoms can emerge up to 14 days after the infection. So it is really something that you have to take care. And of course, wearing masks when in public places. Stay at home with fever or cough. You have to contact your doctor or local health office by phone and discuss how best to proceed. Thank you very much.
Sorry, I hope now you can all listen to me. Sorry about this disruption. Thank you very much, Professor Lubata. Now, the next speaker I have to invite is Professor Fanti. He's based at the University of Bologna, a very well-published researcher, more than 375 publications, 30 books, several chapters, over 120 international speeches, in presentations at meetings. He also happens to be the chairperson of the European Association of Nuclear Medicine Congress, scheduled for 2020. So he's got a lot of interesting things to tell us about this event, the handling and the future and the impact of this ongoing pandemic on the educational activities like the ENM. Okay, over to Professor Fanti.
Thank you very much, Humayun. I hope you can hear me. Everything is okay. Well, thanks for the great invitation. Humayun is a great friend, and I would like now, if possible, to share my screen and let you know which has been the situation in northern Italy and try to bring you some message of hope. Because as you may know, Italy has been the first country in Europe to be severely hit by COVID-19. Indeed, after China and then a few cases in Korea and in Iran, Italy has been severely hit at the very beginning of this year. The first cases reported are end of January. Indeed, they were Chinese tourists, but the first local cases were mid-February with first cluster, and unfortunately the first death recorded on late February. Well, as you can see, Italy has been affected very differently. So most of the cases were concentrated in the north, which has clearly been more severely affected. This is a graph of late March. As you can see, at that time, Italy, unfortunately, was a country with more cases, with more rapidly growing rate, and the highest rate was reached at the end of March. So at that time, we were the country with more infection, with more deaths. But you know, the sooner you get the infection, the only advantage is that the sooner you get out. So we started declining on mid-April, and the curve flattened down. The lockdown in Italy starts much earlier, to say very early March, and indeed it worked. So there's been a reduction in the increase. As you can see, in April, we have flattened the curve. Well, overall, at present, we have recorded more than 240,000 cases with 34,000 deaths, so a very high price. And again, as you can see, that the spread has been very different around the country, mostly concentrated in the north. In a country which I live, which is mid-north, situation has not been so terrible indeed. And luckily enough, right now, as you can see, the curves is really, really low. So as of 2 days ago, there have been something like a bit more of 200 new cases in the area of Bologna, which is something like a 4 million people area. Yesterday, we got only 24 new cases and 1 death. So essentially, here is a word of hopes. I mean, we are getting out. Of course, nobody can predict if there may be a second wave or not. We, of course, hope there won't be. But to every extent, we are in the almost new normal situations. That to say, the lockdown is no longer around. We can almost freely move. Since last week, flights in Europe have been starting again. We can go to holiday. So that's my message of hope. And as said by Enrique, my great friend Enrique Estrada, IAEA has played a great role in this pandemic. They really have taken this worldwide leadership and organized those webinars that were really, really very useful and well attended. And that's from one of that, everybody knows about the phases of pandemic. So in Italy, to every extent, right now, we are in the post-peak for sure. But there has also been the concept of phases for the nuclear medicine department. That's to say, we have a red phase with when it's in the most severe part of the curve and restriction are there. So you are essentially forced to reduce your activity and to just keep running the very essential exams and activity you should do. But most likely, even in Pakistan, you're now moving to the amber phase. That's to say, the restrictions are then becoming less severe, so limited just to a part. You can start again increasing your capability of working, and the capacity comes back to about 70 to 80%, as shown by Humayun. Of course, you have to continue using your PPE, planning some shifting, and keep, of course, running all the communication and remote reporting, remote activities as much as possible, and having new rules for reducing the contacts among patients. And finally, the green phase is what we have right now in Italy, and I hope that everybody will soon get there. That's the so-called new normal. That's the capacity should move up to 90 or even better %, so coming to what's been before. But nonetheless, you have to optimize your workforce and implement a better timetable. Remote training is possible done, but also some normal extent, and research should be resumed. So Enrique already showed you this graph. That's to say, in Italy, just like in Southern Europe, because Italy and Spain got some very bad figures and heavy affliction, we have faced the loss of about 50% of our activities, again in the red and amber phase, which has been almost the same everywhere in the world, but now coming rapidly back. This is from my friend Jimmy Bomanji that emphasizes what we have learned, because there are a number of lessons that we have learned. That to say that, for example, the PPI should be continuously used, and so we keep on having face masks and gloves. Well, part of them were already in use, but now it's all well established. The rule of hygiene are absolutely fundamental. Social distancing in the waiting area, screen patient for possible infection. Of course, this is all related to your national law and policies, but nonetheless, all of them have to be regarded as international standard right now. And regard the IAEA webinar, I presented some of the very simple rule that I'm going to share with you right now regarding what is the new situation when you're finally coming into the currently adopted rules, so the post-emergency situation. Despite the fact that you come back to a capacity of 90 to 100%, it's very important to remind the patients that only one caregiver is allowed in order to avoid to have too many, let's say, people around the hospital. And before the exam, we call every patient to be sure that they have no problem. When they get there, there is this distancing which is in place. We ask everybody to have hygiene of the hands. All the staff is behind a plastic screen. In the reception area, there are announcements informing about waiting rule, where the patients could go, where the caregiver should go. And of course, all patients and caregiver are checked for symptoms, temperature, and minimize as a whole the permanence in the department, which is very important again to avoid the spread of the possible COVID, which is still around. So it's important to review your standard operating procedure with respect to patient workflow and avoid mixing up too many inpatients and outpatients. So if possible, different pathways have been identified, even physically in some cases if possible, and the medical consultation should be converted to teleconsultation as much as possible. So for example, for us, all PET scans that usually had a short anamnestic this talk before the exam is now done the day before at telephone. And again, reducing as much as possible the patient and protect as much as possible from non-due relation with other patients and with the staff. And of course, also the equipment should have a checklist which has to be improved for this period, and logistic could be very important. I guess that as a whole, the lesson that we learned from this COVID pandemic is that teamwork is absolutely fundamental. Having been the first European country to be hit, essentially, we had no possibility to apply experience from other centers, from other countries, and unfortunately, several mistakes, of course, have been made, but nonetheless, the great capability of adapting, of flexibility, and the great working capability of all in the staff, everybody from nurses to technologists, to doctors, administrators, made the difference, because we had to invent essentially this reaction, and that's been done at national level, but it's very important to bring it to your department and to your unit level. That to say, there was no prescribed strategy, so we have to really face day by day, and the new workflow has been invented. And a great example, again, to me, has been the reaction, the proactive reaction of EIA, which worldwide provided supply, but also instruction and a lot of information, which are still there. So I suggest all of you, in case you need any suggested information or material, just go and use the EIA resources as Enrique showed to you, because it's very important right now that you get advantage of the experience of the other countries. So that's all. And again, my thank you for inviting me, and thanks to the EIA staff, Enrique Estrada and Diana Paez.
Thank you very much, Mr. Fanti, for such a lot of detail, the good work that was actually done right in the beginning and that has been carried on. Your insight into the whole thing has been pretty helpful, I believe, for the entire audience. Now we go to our third speaker, Professor Robert Wagner, Professor of Radiology and Nuclear Medicine at the Loyola University Health System in Illinois, USA. Professor Wagner is a well-renowned nuclear physician, multiple research publications, over 50, multiple book chapters and illustrated chapters, atlases to his credit, and he will give us an insight about this whole pandemic situation from USA. It's very interesting because from our part of the world, we all look up to US for most of things and many things. And this pandemic has been quite revealing in this aspect. So over to Professor Wagner. Thank you very much, sir, for joining us.
And thank you very much for inviting me. It's much appreciated. We actually learned a lot by watching what happened as the virus moved from east to west. And we had the advantage of responding as such. So I'm going to tell you a little bit about my health system and where we're located. We're located in Illinois, in Chicago, pretty much straight in the middle of the United States. And we have a pretty large campus, including a large research presence. We have a medical school, a nursing school. We have our main hospital, the Loyola University Hospital, and we have 2 additional hospitals that are several kilometers away that are more community-based hospitals. I am in charge of the nuclear medicine at the Loyola University Hospital and the Gottlieb Hospital. So I'm going to go over some of the changes we put in place there. The introduction of the COVID-19 impacted all of our operations, and the first thing that happened was the research building pretty much was closed down. All of our education was closed down. All the research was halted. Any research on patients again was stopped, with the exception of any life-saving protocols that were in place. The only other thing that was not halted was the coronavirus research that was continued during this period of time. But for medical schools and nursing schools, all of those students had to stop, and we rapidly introduced teleeducation for these students. So it was not very long before they began going back to their classes. At the medical centers, we had to respond to the quarantine. And in nuclear medicine, most of our patients are outpatients. And we saw a significant drop in our numbers. And this also represents a significant amount of the revenue for the medical center. So the medical center found all of a sudden a significant decrease in the revenue for operations. So this impacted the low volumes, impacted administrators, physicians who had to be reassigned sometimes to different duties or decrease their efforts. Those residents, physicians who were in training were reassigned to other areas, and other healthcare personnel had to decrease their hours or reassigned to other areas. Our own department, we saw somewhere between a 50 and 75% drop in our volume. We did not have a problem with isotope availability. However, because of the quarantine, we did not see very many patients. The biggest thing that I noticed was the fear of the unknown, and we found that the fear was not just in the patients, but it was in our staff as well. There were a lot of questions on protocols. Again, some of these were addressed by the IAEA and some of the other information that was published. There was questions on protective equipment use and when to use it. And of course, there were shortages of some equipments as well. Some patients did not have a choice. The cancer patients who were on chemotherapy protocols, cardiac patients who were coming in with chest pain, all of these had urgent needs, and we tried to support them as much as possible. The elective procedures such as DEXA, gastric emptying, elective bone scans, or even elective PET CTs looking for solitary pulmonary nodules. Some of these were delayed to comply with the quarantine need. Our supplies, basically we had 5 fixed gamma cameras, 1 PET CT, we had 2 gamma cameras, and we had xenon ventilation at Loyola and only aerosol at Gottlieb. The benefit that we had over at Loyola, however, was that 2 of our rooms were negative pressure rooms, and we were able to use these rooms because we had them for xenon for the COVID patients. It helped to make sure that the rooms stayed clean. We also had a portable gamma camera that we were able to take up to the floors and to the intensive care units. While the SNMMI did not recommend against directly doing ventilation studies, they did suggest using caution. And as a result, we did not really use too much ventilation at all. Technigas, I understand, is significantly better, but Technigas is not currently available in the United States. So our response was we dedicated 1 room for scanning for COVID patients or those who were under investigation. We even had a video camera so that we could mount that in the room and we could watch the patients. So during the uptake phase of the isotope, they were always being observed. We didn't have to have a staff member in the room at all times. For the known COVID-19 patients and patients under investigation, we always use the highest levels of PPE. We prefer to perform them as a portable study if at all possible. All lung scan orders, in fact, all orders, were scrutinized for appropriateness, and we deferred ventilation. In doing so, we did have to use our skills to try and identify whether it was a low probability or a normal scan, or it would just be consistent with, but not diagnostic of pulmonary embolism. And we needed to balance our care for our patients with the staff safety. For all patients without the COVID symptoms, we had standard enhanced precautions, hand washing, masks, hand gel, and social distancing were all encouraged. And as things moved on, we started doing screening of all patients as they came through. Our general nuclear medicine imaging saw a significant decreased volume. We remained seeing those patients with some myocardial perfusion imaging, although very low. Lymphoscintigraphy continued because oncologic surgery had to continue. And some other studies were reviewed and performed as needed, and there was some urgency to them. PET-CT, again, very important in cancer management. Many of these cancer patients were in the middle of their protocols and they needed to be evaluated. We tried to continue PET-CT as much as possible. If any of the patients had suspicion for being COVID positive, we tried to remove all of the material from the room. We had our staff in full PPE. 2 technologists, one were hands-on, one of them was a little bit in the control area, and the full room was wiped down afterwards. And we tried to make this the last study of the day. Iodine-131 therapies were all deferred if the preparation was not already in progress. So that really decreased significantly, and we targeted June, just by guess, to try restart our routine therapies. And this was basically by looking at the timelines that I was seeing coming from other countries. The Lutathera and Y90 spheres were continued as usual. We really adapted and started doing the consultations via video connection. Patients and physicians both embraced it, and I believe it worked well, and we continue to do this today. For our physician presence, we only had 3 full-time nuclear physicians taking care of all of this. 1 stayed on site, did the hands-on procedures, therapy, and answered questions. 2 performed the majority of reading from home, and the 1 person was basically doing all the hands-on procedures. We already had remote reading technology, so we sometimes support reading from home or perform call from home, so we had workstations there as available. Our technologists were reassigned, and many of them were assisted with environmental services, helping to clean on some of the floors and with the COVID patients, and others took leave of absence. Communication was identified as being very important early on. There was a nightly update from the director of nuclear medicine, myself, to the technologists and the nurses. They found that very comforting, and many policy changes happened quickly. So this nightly update was very welcome by the technologists and nurses. It allowed questions and problems to be addressed, and there was a consistent and familiar voice of reassurance, which helped to decrease the fear. There were flyers in waiting rooms explaining our efforts to keep the patients safe, clean the areas, and maintain distances, and we expanded some of our waiting areas to assist in the social distancing. Currently, we are returning to our volume. We are currently at about 75% of our normal. The number of COVID patients in the hospital are decreasing, All of our patients and staff are screened on entrance to the hospital. We have visitor restrictions so that there is only one person who can accompany a patient when they come, and all patients get masks. We still have a inconsistent volume, and rapid testing has decreased uncertainty. Physicians now are returning to work locally. With that, I come to the end. I thank you for your time and appreciate your attention. Thank you.
Okay. Thank you very much, Professor Wagner, for your detailed insight. We got a chance to see all the practices that's in place in US and how the workforce has been utilized. That's very useful for all the audience. Our next speaker is Dr. Saima Riaz. She is the consultant nuclear medicine physician based at the Second Shokat Hospital, COVID-19 Hospital in Peshawar. And she will be discussing a PET-CT case with findings relevant to our current pandemic. So it's over to Dr. Sam. Sorry for the slight delay, we're just trying to work out how to display the slides.
Good afternoon. Dr. Maya? Hello. Good afternoon. Hello. Anika, can you hear me? Already on. Can you see my slides? Okay. Assalamualaikum. Good afternoon. Thank you, Dr. Mayo. I hope everyone is keeping safe. In my presentation, I will be running through the PET-CT imaging in the current times. Hello. Okay. Hello. Can you hear me now? Okay. In this presentation, I will be running through the PET-CT in the current times. The valuable stuff on the precautionary measures to be taken in the nuclear imaging has already been covered in the earlier presentation. But here in this, I will be focusing mainly on the imaging features of the COVID-19 infection, basically for the trainees. Out of interest, as all of us are following these numbers, by June 21, COVID-19 has infected about 165,000 people in Pakistan, with a report of 3,200 deaths. In nuclear medicine, we do not have a direct role in the diagnosis of COVID-19, but we have come across the incidental detection in asymptomatic but infected patients who are referred for different indications. Here, I would like to share a case with you. It was a 38-year-old male with relapsed Hodgkin's lymphoma who was referred for F18-FDG PET-CT scan after completion of a second line of chemotherapy for the end of treatment evaluation. For this patient, the COVID-19 screening for the symptoms and travel history was unremarkable. And this screening is usually done in routine for every patient coming to our hospital. In this slide, you can see the lung windows of F18-FDG scan. And here, there are scattered ground glass opacities in both lungs, which are FDG avid, predominantly pleural based and in posterior location. The most avid lesion in right lower lobe has an SUV of 4.6. Otherwise, this scan was unremarkable for the disease, in terms of the lymphoma disease. So this patient was, these imaging features were highly suspicious for COVID-19 infection. This patient was immediately notified for screening and the testing for COVID-19 was done. Home isolation was advised and this patient remained asymptomatic during the next 2 weeks. After the scan, the PET machine was disinfected as per protocol and employees getting in contact with that patient were also screened. So, as we know that CT is a routine preferred method for screening, diagnosis, and to evaluate the severity of the course of the disease during this COVID-19 pneumonia. I will just go through the imaging features on CT scan for the trainees. Here you can see the chest CT scan. The ground glass changes are seen in this first image, which is on the left top. There are very subtle ground glass changes in the posterior location in bilateral lungs. A more diffuse pattern is seen in the second image, and you can see these nodular changes in the inferior image. So ground glass changes are the most common finding, which is usually multifocal, bilateral, and peripheral. But in early phase, it may present as a unifocal lesion, most commonly in the, it is most commonly reported in the inferior lobe of the right lung. And you can see that in all these images, there is posterior predominance. The non-peripheral distribution has also been reported, but in a very few cases. Hello. पहले पे hold हुआ हुआ है। आप क्या कर रहे हो? I'm sorry for the interruption. You were not able to see my slides. So I will just quickly run through the PET CT images. So here is the lung window of the FDG PET CT scan. And as you can see, these FDG avid ground glass opacities in the posterior location in bilateral lungs. I was actually describing the CT features. So the most common feature is the ground glass changes. And in the initial phases, you only see very subtle phase changes in the peripheral location. And as the disease progresses, you can see the diffuse pattern and the nodular pattern as well. It is usually multifocal, bilateral, and peripheral, but in early phase, it may present as a unifocal lesion, which has been most commonly reported in the inferior lobe of right lung. And you can very well see there is posterior predominance in all these images. When these ground glass changes progress and develop interlobar or interlobular thickening, then this feature is given a characteristic name of crazy paving, but this is usually seen in the later phase of the disease. The next thing which is seen is the consolidation, which can be lobar or it can be segmental. And the other features which are reported to be typical for COVID-19 infection are the bronchovascular thickening and traction bronchiectasis as well. So the primary findings on CT are ground glass opacities in peripheral location and bronchovascular thickening. In a study which has been published in American Journal of Radiology, where they actually studied 900 patients for the early features of CT findings, and you can see that ground glass opacities in bilateral location has got the highest percentage, as you can see, 88% and 87%. There are reports of some atypical findings as well, which have been reported in 5% of the patients. And this actually raises the concern for superadded bacterial pneumonia. So the atypical findings may be mediastinal lymphadenopathy, pleural effusion, the pulmonary nodules, as we have seen in the previous image as well, pneumothorax and cavitation. A similar study from China, which was again published in American Journal of Radiology, where they studied CT features in the early and advanced phase of the disease. The early phase was within the 7 days of the commencement of symptoms, and the advanced phase was after 7 days. And again, the bronchial changes, air bronchograms, pleural effusion, and thickening, these were the features of delayed phase of the disease. So if we see the changes which develop over time on CT, these have been divided in 4 stages. In early phase, CT is either normal or has got ground glass opacities. In 50% of the patients, the CT scan is normal within 2 days of the onset of symptoms. In the second progressive stage, which is usually within 5 to 8 days, there is extension of the ground glass opacities. And as I have already mentioned, there's development of crazy paving. And the third phase is the peak stage, where there is development of consolidation within 10 to 13 days. And in the late phase, which usually comes after 14 days, the fibrous changes appear and the abnormality resolves in almost a month. CORADS by Dutch Association of Radiology and COVID-RAD from US are the imaging reporting and data systems where CT scoring has been proposed. CORADS 1 and 2 have low or no suspicion, 3 is for the indeterminate findings, and 4 and 5 are highly suspicious with ground glass opacities and consolidation. CORAD 6 is given where there is definite diagnosis in hand with PCR positive and CT findings. So this is actually the course of disease on CT scan. Coming to the metabolic component, which is the PET component of PET-CT, since all inflammatory processes, as we know by convention, are FDG avid. So this COVID-19 infection is also FDG avid. As in acute inflammation, the activated neutrophils are highly dependent on anaerobic glycolysis, requiring increased glucose and resulting in high FDG uptake. On PET-CT, in a couple of case reports, they have seen mediastinal lymphadenopathy more on PET-CT as compared to the conventional CT. And this phenomena has been studied by Sheffer et al. And they actually reported this. This is related to the increased monocyte percentage. And since we know that PET-CT is more sensitive to pick the early metabolic changes in non-enlarged nodes, so the mediastinal lymphadenopathy and even the axillary nodes are more commonly seen on PET-CT as compared to the conventional CT scan. Whatever the stage of the disease is, there is a hypothesis that the uptake pattern and the intensity of FDG is helpful in the monitoring of the course of the disease as well. And it has been reported that higher FDG uptake in these lung lesions take longer to heal. So we can say that PET-CT is also a prognostic indicator, though this is not the prime modality to evaluate and to assess the course of disease of COVID-19 on PET-CT. So, to sum up, the proportion of patients with mild or no symptoms is still underestimated. The oncological patients might be at increased risk of COVID-19 because of their immunocompromised state. So the earlier diagnosis of these positive cases can limit the spread of infection within the population and the exposure of healthcare workers, and this has its own impact on the ongoing treatment of these patients. We as a nuclear medicine physician should be able to evaluate the CT component of PET-CT exams while performing these studies, so that we are able to identify the imaging findings suggestive of COVID-19. And in this way, we can give our contribution even if it is minimal. Here are the references of the images and the studies I have presented here. Thank you very much for your patience, and I will be happy to answer your questions. That is all from my side. Thank you, Dr. Mayo.
Thank you very much, Dr. Simon, for this case presentation and actually putting quite a few things back in perspective and focused, which I think the juniors will be really happy to have a chance to go through. Now, I would request Dr. Amna Hassan, the consultant nuclear medicine physician at Job Khan Hospital, Lahore. She's an American board in nuclear medicine. She's been with SKM for like 7 years now, and a very vibrant and research-oriented member of our faculty. And she'll basically be, discussing the new situation that we are in. Over to Dr. Amna Hassan.
Assalamu alaikum and good morning. I'm sorry we had some technical issues here. It's been an exciting session, and I'm going to bring it. I'm going to bring everything on to current times as we transition to the new normal. COVID is going to be with us for a while, and we're going to. Sorry, we're still having a few issues here with the presentation. So for us, actually, the most interesting thing is we've always practiced time, distance, and shielding in terms of radiation for nuclear medicine. In the current COVID era, it's the same principles: time, distance, and shielding. Decreased time spent with patients. You don't know who all may be infected. So increased distance between patients, and shielding would be the personal protective equipment. A LARA concept here also works very well, as low as reasonably achievable. So the virus load to each of us, if infected, we hope is as low as reasonably achievable. For general protection, our hospital has a very robust policy where every person entering the hospital is masked. Only one attendant will be allowed. Patients are counseled to arrive only 30 minutes prior to the appointment. Screening questions are asked by staff outside the hospital in terms of fever, etc. And then once they come to the nuclear medicine reception, further questions regarding travel to outside city or country recently, or visit to a crowded area is seen. And further, patients are counseled and attendants to frequently use hand sanitizers. So one of the changes that we're facing in the current practice with COVID and its current status is we have to identify high-risk procedures. It's important to know what procedures can be done and what cannot be done, or can be proceeded with caution. I saw that we've already referred to this practice guideline, but this was an interesting way in which the American Society of Nuclear Cardiology and SNMMI have put forth a guidance of prioritizing myocardial perfusion imaging. So priority 1 is assigned to studies which should be done, obviously with caution. Those would be recent acute coronary events in moderate to high risk patients who need urgent coronary revascularization, or if someone has new or accelerating symptoms or there's suspicion of coronary artery disease, however, risk for performing coronary angiography is high, that would be a priority 1. Pre-op evaluation in high-risk patients who have to undergo an urgent surgical procedure, that's priority 1, and tests should be performed. However, someone with stable angina and there's no plan for urgent revascularization can be a priority 2 or 3, and you can postpone the test as well. Similarly, for F18 FDG PET-CT studies for viability, similar categorization and priority assignment is also done. If someone has is scheduled for a CABG in the next 2 weeks, and you need to see if there's viability, that's a priority 1, and the study should be performed. Someone with stable ischemic cardiomyopathy is not an urgency, so it is okay to postpone the study. For technetium pyrophosphate imaging in cardiac amyloidosis, based on clinical condition, it can be a priority 1 or 2 for performing the study. Given different indications have different priorities, so sarcoidosis, initially a patient presenting with heart block or VTAC, suspected cardiac sarcoidosis, it is a priority 1 or 2, and a test can be performed with precautions. However, in a follow-up case, it's okay to postpone the study. And as you can see, similarly for infective endocarditis, someone with suspected prosthetic valve or device infection, proceed with caution and taking appropriate precaution. We are a cancer center, so MAGA studies, if needed to be performed, are priority 1. Someone who is initiating a cardiotoxic chemotherapy regimen, or we are doing a follow-up subsequently, it's a priority 1, and then test can be performed. based on that. Liver transplant, if someone is about to undergo it or has a poor life expectancy from the liver disease without the transplant, then it's a priority 1. However, renal or heart transplant can be a priority 2 or 3 and test can be postponed. In terms of acquiring myocardial perfusion stress testing, so exercise stress is not routinely recommended because there is a risk of to the operator as well during the exercise. So pharmacologic stress with vasodilators would minimize droplet exposure to the staff and also contact. Here in Pakistan, we don't have regadenoson. However, if available, it is the preferred stress agent because it's a single 10-second infusion. And the provider can maintain distance. However, if adenosine or dipyridamole is to be used, an extra long tubing can be used to increase distance. Automatic blood pressure cuffs can be considered. And however, if exercise testing is absolutely necessary, then the personnel should have proper PPE based on the local institutional guidelines. The other study I'm going to talk about is ventilation perfusion scan. So as we know that COVID-19 has a lot of respiratory symptoms as well, and then there's a component of thrombosis. However, VQ scan, we do the ventilation portion with DTPA, so there is risk of aerosolization. So currently, ventilation scans are not being performed. However, SPECT-CT is being done with perfusion scan. This was a very good algorithm which a hospital in Liverpool is using. So if a patient is pregnant and they, I hope everyone can see this a little bit. So if there's a low risk for COVID, then it's okay to proceed with SPECT-VQ. If there's a high risk in the patient for COVID-19 and the X-ray is normal, proceed with SPECT-CT. If there's a high risk for COVID, but the X-ray is abnormal and there's a high suspicion, then you proceed with CTPA. All non-pregnant patients or males, if there's a high suspicion for COVID-19, you do a CTPA instead of a VQ. And if there is a low suspicion for COVID-19 with an abnormal chest X-ray, you do CTPA. If the X-ray is normal, then SPECT-VQ can be obtained. Keeping in mind that in cases where it is mandatory or we have to do the ventilation portion for some reason, then this just puts forth the different PPE levels that can be recommended to the technical staff for their own protection. So obviously, if the aerosolization is going to happen, if the ventilation study will occur, it has to be a negative pressure room with proper extensive PPE for the technical staff. One of the things that have changed, every scan is reviewed for findings, and as we have just seen detailed findings on CT by Dr. Saima as well. Every scan, every SPECT-CT that is acquired with any imaging is carefully looked at for any imaging findings within the lungs that may be suggestive of COVID-19. A large series, about more than 1,000 patients, showed that there's a 97% sensitivity of chest CT for diagnosis of COVID-19. This sensitivity is greater if the scan is done 3 days after symptom onset. It's also been seen that within the first 2 days of symptom onset, only about 56% of patients may actually have a normal CT scan and may be missed. Now, in our case, we're seeing patients who are absolutely asymptomatic. They have been screened outside and scans are performed for other oncologic reasons, and we find incidental findings which are suggestive of COVID-19. I present to you a case of a 65-year-old diabetic, hypertensive lady who underwent a technician bone scan for shoulder pain. She has a history of radical mastectomy and chemotherapy for breast cancer in 2007, followed by a second primary malignancy in 2018, HCC, for which she underwent transarterial chemoembolization. On her scan, So on the bone scan, you can see we saw these area of uptake in the right-sided anterior ribs, and we went ahead with a SPECT CT scan. There is a distribution of ground glass opacities and nodular infiltrates in both lungs. These findings were felt to be suspicious for COVID-19. Patient was sent to the COVID camp, and patient came out to be positive. Here is another patient, 56-year-old with newly diagnosed right breast cancer. You see infiltrates in both upper lobes of the lung. Patient was sent for COVID testing and was found to be positive as well. Both these patients subsequently did well and recovered after about 10 days or so. So whenever an incidental finding is found, patient goes to the COVID camp for detailed assessment. A critical alert is raised, the clinician is informed. The results are followed by our COVID and infectious disease team, as well as the department, because it's important for contact tracing. This is just a sample of the triage questionnaire that the COVID camp asks. In terms of keeping our department as clean and clear from COVID-19, we space out the patients. Currently, it is we believe that every patient must be treated as if they may have COVID-19, although their care should not be compromised in any way. But by spacing them out, we're able to clean up the equipment in the middle. Known COVID-19 patients are scheduled for the end of the day. And then one of the things that that have been introduced, all thyroid clinics stopped in March, and then in May of this year, teleclinics were started. We contact patients by mobile and WhatsApp numbers. Detailed histories are acquired, orders are placed within the system, and if any blood test needs to be done, the Shaukat Khanum network is all over the country, and the patient is able to go there, get the blood test done. There are, however, some challenges with teleclinics as well. Phone call conversation does at times lack the personal touch of a face-to-face encounter. There may be language barriers. Some of our patients, we have to communicate to them through a translator. There may be different levels of understanding, and written instructions cannot be provided directly. At times, the process does get to be a little laborious. However, in order to reduce the possibility of any communication error, we do try our best to repeat and have the patient repeat to us as well. And then we ask them to take notes in the background and read them back to us. So we try our best to make the system work to the best of its ability. At times, technical issues may also be found. And lastly, safety of our staff is obviously of paramount importance. In case of exposure, there's daily check, contact tracing, and on top of that, the psychological, social, and financial distress that, given the current scenario, if any staff member is feeling, we do have avenues within the hospital which we encourage them to face. And lastly, professional development. Since this has been going on for about 3 months now, we are encouraging web-based learning, and that's about it. Thank you so much.
Okay, thank you very much, Dr. Amazin. This brings us down to the end of the webinar. Thank you very much for all the contributors and speakers. It has been a wonderful experience to hear from literally all over the globe, from Europe, from US, and from Pakistan. I just had one last slide to put on display, which I would just anyway. Okay, so this is the concluding slide for this webinar. Thank you very much, everybody, all the speakers and the audience. I've taken this quotation from the movie by Gabriel Marquez, love in the time of cholera. So we are dealing with nuclear medicine in the time of COVID-19, and as the author said, no, not rich, I'm a poor man with money, which is not the same thing. This first pandemic of the 21st century has been a great leveler. Resources or lack of resources, many felt the similar problems and uncertainties. The post-COVID times will be financially challenging for every level of administration in society, institution to society, as well as governments. The silver lining is, optimistically speaking, the post-COVID world is likely to have greater focus on social services and healthcare systems, and a discipline like nuclear medicine, which is very technology intensive, will have to put an effort to get its deservable or its adequate chunk from that allocation of resources. There might be more, but there will be more contestants. Our equipment is expensive, our consumables are expensive, the movement of our consumables is expensive. We got to innovate, we got to look into those things that cyclotrons are producing, technetium as well as gallium-68, and we have to make things easier for our patients. That's the ultimate purpose of our discipline, like any other discipline. Thank you very much, everybody, all the speakers, Dr. Fanti, Dr. Labato, Dr. Wagner, Dr. Amna, Dr. Saima, and the audience from across the globe. Thank you very much.
Thank you for the opportunity.